Welcome. I'm Lee Doherty Biddison.
And I'm Carolyn Cumsty Fowler, and we are your co-hosts for the Johns Hopkins Medicine Office of Wellbeing's podcast, Vital Conversations, Influencing Workplace Wellbeing in Healthcare.
We spend a lot of time thinking about how to influence workplace well-being in healthcare, and we're excited to share some of what we're learning.
Thank you for joining us. Hello, I'm Carolyn Cumsty Fowler, and I'm the host for our podcast today. And it is my pleasure to introduce a colleague and friend, Dr. Karen Swartz. Karen is a psychiatrist and professor of psychiatry at Johns Hopkins School of Medicine. She's director of clinical services at the Johns Hopkins Mood Disorders Center and director of the Johns Hopkins Adolescent Depression Awareness Program. And throughout the pandemic, Karen and I were part of a collaborative that worked together to support the mental health of our colleagues at Johns Hopkins Medicine. Karen, it's so good to have you here with me today.
No, it's my pleasure.
We've talked quite often, you and I, Karen, about the fact that clinicians are not good patients. Could you tell us a little bit more about that?
Well, Carolyn, it's startling. They have some data that only 35% of physicians have any regular source of healthcare. In general, I think all clinicians have enough knowledge that they think they can manage things and tend to only get care when they feel that it has gotten to an urgent or emergent level, which obviously is problematic in all kinds of ways, but particularly problematic for psychiatric issues.
Mm-hmm. So before we move into the mental health realm, are you saying that they're not getting much care in general across the spectrum of healthcare?
Absolutely. They're not getting preventative care. They're not having regular check-ins. They're not perhaps getting the screening tests that others get. We have knowledge, clinicians do, that allows us to recognize maybe when a new problem has started and then take action. But it is not a good thing when you take a group of highly educated people and you find that a third of them don't see anyone regularly, especially given as people age. Obviously, it's a part of your health to be able to get regular check-ins and annual visits to make sure there aren't issues that need to be addressed.
Wow, absolutely. So then what's different when we're talking about clinicians receiving care for depression?
There are a couple things that are different, Carolyn, but I think the one that people think of first is the stigma associated. It is not, no one wants to be battling cancer or dealing with that, of course, but they're not embarrassed about it, I hope, in 2024, in the way that people remain very embarrassed about needing psychiatric treatment for depression, anxiety, or other issues. So doctors don't want anyone to know that they're dealing with it. And there are enough societal discriminations that you worry too. I recently had someone who needs records to get insurance. And the fact that the person has responsibly had very successful treatment for depression could influence their ability to get life insurance or disability insurance. And that's just wrong. So when people say there's discrimination, there is. But then on top of it, there's the view that this is something that people will think differently of me or doubt my abilities or doubt my ability to function as a clinician if I am someone who's had depression or anxiety.
When you say clinicians, Karen, are you referring only to physicians or to other clinicians?
Oh, all clinicians. Sadly, when you look at the people in the hospital who you would hope have seen people benefit from treatment and that would influence them, it's just not the case. Because I think that people that are highly responsible and self-sufficient tend to become physicians and nurses and respiratory techs. And so you and I saw this during COVID across the board. So many different people that were in healthcare, on the front lines of healthcare, were not taking great care of themselves. They were sacrificing to take care of everyone else, but they were not great at taking care of themselves. And they have this sense of, I should be able to handle things, which is really problematic.
So if we were to dig a little deeper here and go beyond the stigma and beyond the reluctance to seek care for whatever reason, are there things about depression itself that we should be thinking of?
There definitely are. And one of the most important is depression itself changes your self-confidence. It changes your view of yourself. And so one of the symptoms of depression is that you start thinking that you're lazy or you're not talented or you're not someone that people would want to be around or that people can count on. So it could be that you're functioning just fine in your role as a nurse, as a doctor, as someone working on the unit, but you'll start doubting yourself in a different way. And so what happens is when people are depressed, they've shown in surveys of clinicians that when you're depressed, you're more likely to have these negative views of yourself than if you're not depressed. And so you start saying, oh, people are going to see me differently if I get care. And the sense of I'm just a screw up and I just need to get my act together, that's part of depression. So many patients over the years have told me when they're depressed, I don't really think I'm depressed. I think I'm just being lazy. I'm not really depressed. I think I just need to work harder. Or maybe I'm just not applying myself. And I'll talk with them and I say, you don't say any of these things if you're well. These are all the things you tell me when you're depressed. But imagine that with someone who is naturally high expectations, very hardworking, they start believing themselves. I mean, depression means that you lie to yourself. Your thoughts get distorted. And so why would you not trust your brain? We have highly educated people in clinical roles. They're used to trusting what their brain tells them. So when your brain starts saying, you're just lazy and really no one wants to be bothered with you, and you start believing that, which is painful.
It must feel very lonely.
I think that is a perfect word for it because it is so isolating. People feel that, well, first they feel that others cannot understand them. And unless you've gone through it yourself, that might be true. But they also feel that they're not worthy of other people's attention or their love or their concern. And so it's that sense of I'm just going to go and hide in a hole, so to speak. If people are already feeling like they're different or they're less than. And I think it's tremendously lonely. And I think it's incredibly painful. And because people look okay, and sometimes even at work, they can function at a high level, it often gets missed, which is terrible.
And to what extent does the diminished motivation influence the likelihood that they'll seek care, do you think?
Well, lacking motivation certainly doesn't help anything. Sometimes it leads to there being problems in functioning. So that does it. That can do it. But I don't think people have any confidence that treatment will work when they're depressed for a couple reasons. One, they don't think they have a treatable medical problem. Two, if they believe they have depression, they think they have a form that won't respond to treatment. Well, there's no hope for me, that kind of a thing. Mm-hmm. And then the third thing is that the energy to make a call, to track down someone that can take care of them, to, in this day and age when it's sometimes hard to connect to services, being, sort of going through that. I'll often say to friends who say, what can I do to help? I said, you can identify someone who can see them and offer to take them to the first appointment, or make sure their computer's set up if it's going to be telemedicine, because the energy to just initiate all of that, someone with really severe depression may not have it.
So Karen, if you're the clinician, if you're the psychiatrist who's working with a clinician and you get a sense that their level of depression may in fact be influencing their ability to function as a clinician, even in the short term, what would you say then?
I think when people are in certain roles where they're influencing other people's health, other people's safety, we have to be careful. So if someone's a nurse, they're a doctor, they're, working respiratory tech, something like that. We have to make sure they're actually functioning. And if they're not, it's the same way that you wouldn't say someone should keep working if they're in the middle of an intensive period of chemotherapy. Mm-hmm. Sometimes people need to take medical leave. Often they don't, because the depression thankfully doesn't get that severe, but it's possible. And it's really important that the clinical team taking care of them takes that seriously, has an understanding, and that they themselves understand that I don't want to compromise my ability to function because that would obviously compromise someone else's care.
And what if it's a colleague that we're working with and we're concerned that there's something going on? Clearly, we're not the experts, so we're not making a diagnosis. But at the same time, there's just something about the way they're showing up that has us concerned, either that they're truly depressed and need help for that, or perhaps that they're not quite functioning at the level they've been functioning at before. How should we approach it? Because we don't want to impose any additional harm on them. So what's the right way to start this conversation?
That is a challenging conversation to have, Carolyn, because it depends on what your relationship is with the person. If it's your closest friend at work and you have a really long-standing close friendship, that's someone you might talk to directly and say, I'm really worried about you. I've known you for 20 years. You're not yourself. These are the things I'm seeing. You're coming to work and you look a little rough. You look exhausted. I've noticed you don't have your usual confidence. All of these things worry me. And, I've identified a resource. I think it would be great if you would at least get this evaluated. But most of us aren't going to have that relationship. And so then you have to think, who is the right person to have that conversation? And it might be that you express your concern to clinical supervisor, because that leader will have a responsibility, can get information about functioning, can check. And if there is an impairment in functioning, can be in a different position to talk about, we really need you to do this because we just need to make sure you're okay. It is the usual thing to want to ignore this because it's such an awkward position to say to someone, I'm worried about you. I will tell you, years ago, I was anemic for a very treatable reason. But my friends on the floor, especially the nurses, came up to me and said, what is going on with you? You're very anemic. And I was so grateful because I said, oh, this is what's going on. This is what I'm doing. I said, well, we care about you. We don't want something happening to you. And that's all straightforward because it was such a straightforward problem. Imagine trying to have that conversation when someone's saying, I'm fine, because they're telling themselves they're fine, versus, you're right, I'm in the middle of a terrible depression. I can't think, and I'm worried that I'm never going to be able to work again, and all these other worries in their mind. But you have to say something. You owe it to the person. And of course, we have to protect the patients. And that's what's different about taking care of clinicians than, say, someone that has another kind of role where their work doesn't so directly influence the safety of others.
Mm. During the pandemic, we saw so many people with a full range of experiences. For some, it was stress, maybe just getting into that yellow level of getting towards distress. And then saw people going through burnout and into full-scale depression. Could you maybe talk a little bit about that range of experience across that spectrum that we experienced during the crisis?
Absolutely. And I think that goes on because clinical work is incredibly rewarding, but it's also hard. It's emotionally draining. It's long hours. It's high stress when you're on duty. And so I think that continues. I think it got heightened. And maybe one of the only positive things that came out of COVID is that we're having these conversations much more openly. And that perhaps, I hope, people are a little more open to getting help. But there's a level at which people are just getting tired. They notice they're a little more irritable. They're not disliking work. They're not having classic signs of burnout, but they need to take better care of themselves. And that's where saying, am I getting enough sleep? What am I doing in my downtime? What am I doing to refill the tank? Matters. And that, again, is a conversation perhaps friends would have. But that's not going to be at the level that the organization's involved, because you're not noticing anything necessarily. The person's noticing themselves. They're the ones that are seeing it. So that's important, because sometimes that can, especially with burnout, not lead to it getting further. With burnout, of course, people start feeling emotionally exhausted, and they start disconnecting from the patients. They aren't engaged in the way they typically would. And that's been shown to obviously to affect the way people function in their clinical roles. And so that's where time and looking to see what is going on. Are there ways I can change how I'm working? Do I need to do, that's where things like doing mindfulness, again, paying attention to your own stress level, getting more exercise, and thinking about your schedule, perhaps not signing up for extra shifts, making sure that you're working in a way that's sustainable can be helpful. But for others, it progresses into depression. And I will say this, generally, I've taken care of many clinicians in the time I've been at Hopkins, which is more than 30 years. And in general, I would say that clinicians, when they come to treatment, their mood disorder has advanced to a more serious level than the average person because they've tried to manage it on their own, or they haven't taken action, or they were too busy, or all the things, right? All the things that get in the way of going for your general checkup or going to get that colonoscopy or whatever it is. And so then you have to say, we have to do something about this because we don't want it to go to another level where it's actually changing your ability to function.
So what then would you say is the responsibility of organizational leadership in making sure that clinicians who may be struggling are supported?
I think one of the best things that an organization can do is to have some resources available on campus that are easy to access. So if you think about clinicians, think about, the shifts you're working, the different times you're on service, just getting somewhere else to get care can be daunting and be enough of a barrier that people don't follow through. So having available services. Now, some people will appropriately choose their own choice to get treatment with someone who's in no way connected to their organization. I will say that if you're working with therapists, psychiatrists, psychologists, their level of confidentiality doesn't change whether their clinic is where you're working or somewhere else. That has to be absolute. So that's not practically a worry, but I think it's a worry that some people have. Where would I be seeing someone, et cetera? Would someone know? So that having the organization investing in having resources, I think, is one of the most important things they can do. The other is to train their leaders so that they're aware when people are struggling and to encourage them. There was a really interesting thing that happened years ago in the Air Force. They decided to make suicide a number one priority, and they started at the top. And so the top generals were telling the colonels, telling all the way down the line to the youngest people, if we let something bad happen, we've all failed, starting at the top. And that changed the suicide rate in 1 year. It halved it. So this idea that we all need to take this seriously and we have to encourage it, and sometimes we have to be open that we think this is important, or I've myself used this resource, those messages go a long way.
Mm-hmm. So reducing the barriers to the safety.
Reducing the barriers, making sure that there are not unrealistic expectations for work hours. I am old enough that when I was an intern, we had no duty hours, and that wasn't good. It's good that the residents now have restricted hours. The nurses and attendings, it's less clear to me that anyone's paying attention to the number of hours they're working. If people get called in to cover or work extra shifts or just have to do the work until it's done. And so I think we have to think as an organization, have we set up duties for either attendings, senior nurses, the floor nurses, others, where their duty hours are unrealistic or not healthy?
Right. And not just the official duty hours, but the sort of encroachments onto their time when they leave work.
Or their encroachments, they have a shift, but the documentation requirements, and they're there for an hour or two later, and all of that. That we just have to be thoughtful that part of what helps people refuel is sleep and time and energy enough to go do something. It might be really great for any of us to go take a walk on a beautiful day in the park, but you have to have the energy to actually go and do it and the motivation, but also that you just don't think. I remember my internship, we just wanted to sleep. We thought that was the greatest thing you could get to do. And if you're working 120 hours a week, it probably is the best thing you can do. But if you're too tired, all the other opportunities to refuel just seem overwhelming. And I don't think people will take advantage of them or be able to do it realistically.
So, Karen, as we get towards the end of our time, I just wanted to open up another topic, and I hope it isn't too big of a topic, but let's just give it a try. You and I had some conversations about how much grief we thought we were seeing in our colleagues. And then recently, we've seen two other things. One is this sort of escalation of violence and interpersonal violence, often from patients and patient families, which is creating a sense of fear, sometimes even in our clinicians. And then finally, these incredibly rapid change cycles that we're seeing in healthcare right now. How do those come together to influence the risk for depression or other mental health challenges?
Well, Carolyn, I think when you have enormous stress, we know that that is a risk for depression. It probably is that each of us are born with a different vulnerability to depression, like other medical problems. And then what life throws at you makes it more or less likely to happen. And so if you are working in an incredibly stressful environment where pretty much every minute you're at work, you're worrying that a disaster is about to strike. And I do think that with the most frontline healthcare workers, that has happened with this change in violence. So the level of tension and the cortisol levels and everything all day, I do think that's a risk factor, particularly for those that perhaps have a family history or themselves have a history. So I think that's a big factor. And then with grief itself, sometimes that will trigger an episode in someone who's vulnerable. And I think that there's all kinds of grief. I mean, there's obviously the grief of losing a patient or a friend, but there's also the changes of wow, we've really changed how we operate. I think that there's grief associated with thinking we now have to worry about violence in a way we didn't before. That sense of we've lost the ability to work as clinicians. And for many people, they came into this work because of the joy and the satisfaction. And then if you layer on a level of fear, that really changes those positive emotions. I mean, we all spend our day having positive and negative experiences, and you hope on balance, most days it's more positive than negative. Not going to be perfect, but it's really hard if you just feel like I just am exhausted from being at work because I never know what's going to happen and I don't feel safe. It's a pretty basic need.
Karen, I wonder what advice you would give to those of us who work with new clinicians, new graduates, the new residents, the new interns, people who have just finished their training and are coming into this environment, perhaps not fully prepared for what's going to hit them. What should we be looking for, and what should we be saying to them as they come into this environment with us?
I think all of us have a responsibility to our younger colleagues to be there with them. And what I mean by that is it's not just training, but it's checking in. It's finding out if they are well suited to this work. There are individuals I've worked with, one of my own classmates in residency, who really did not enjoy clinical work and had a really successful career doing non-clinical work because after years of trying to get herself to like it, she just never did. So you just have to check in and also find out, is there something, a skill someone needs or guidance they need to make a challenging situation maybe a little less challenging? And so I think we have to be hands-on. And I do think actually that our current graduates, residents, et cetera, are open to that kind of teaching and support more than maybe 10 years ago or 20 years ago, when there was much more of a sense of, I can do it all, I'm ready to roll. And so I think that's good that they're open to it, but I think we need to make time for it as the more senior members of the teams. I think we really have to make time for it.
Well, thank you for being here with us today. And I'm going to give you an opportunity just to tell our listeners anything else you would like to tell us about how to think about depression in clinicians and how to protect clinicians after all your years of experience.
I'll close by simply saying I chose to focus on mood disorders for my career because people get better. When someone's in the middle of the depression, they don't believe it. I've been called annoyingly optimistic. I've been called relentlessly optimistic. And what I always say is my optimism that you're going to come out of this depression and feel well comes from experience. And so that is what the message I hope that people take away. Depression is very treatable. Anxiety disorders, other psychiatric conditions are very treatable. And they take a long time to get better on their own without treatment. And I would hate to think that people are suffering unnecessarily.
Karen, thank you so much for everything you do. And thank you for the gift of your time today.
Oh, my pleasure.
And thank you to you for listening to our podcast. I hope you'll come back and listen to another one very soon. So that's it for today. If you enjoyed what you heard, please share this podcast with a colleague. And as always, we welcome your feedback.
If there are any topics you'd like to hear about, please email your ideas to us at owb@jhmi.edu.